Hi, my name is Zachary Town, and as part of the health equity curriculum, today we're going to focus on hypertension and then discuss the DASH diet in response to treat hypertension. So by the end of the lesson, we want you to be able to define hypertension as put forward from the American College of Cardiology and the American Heart Association, along with listing factors that contribute to hypertension that can be modified. Identify both the personal and public health burdens of hypertension in the United States, being able to describe the disparities in hypertension we see within vulnerable populations, and then being able to describe the benefits and how one sticks to the DASH diet. So just starting off by defining hypertension, if you look in the table to the left, you'll see that stage 1 hypertension, or the beginning of hypertension, has a systolic blood pressure lower limit of 130 millimeters mercury and a diastolic lower limit of 80. And then it can go higher if you go above 140 for systolic or 90 for diastolic, and then you would be considered stage 2. Now, the numbers that we have here for normal blood pressure are defined from the SPRINT study that found that having a blood pressure of 120 or lower is associated with fewer cardiovascular disease events and reduced mortality. Now, the image on the right shows just the general circadian rhythm for blood pressure. If you look, these are on forced 28-hour periods and forced 20-hour periods, but the results hold consistent for 24-hour periods that we stick to as well. And so if you have patients who are measuring at home, keeping a log, it's okay to tell them that it might fluctuate and that if they record at different times, getting different values does not mean that their blood pressure is out of control. So let's discuss some of the factors that contribute to high blood pressure. We have things like obesity, whether you smoke or drink, whether you have a lack of exercise, and then there's also genetic factors and dietary factors. What's worth noting is that as far as genetics go, there's over 140 known mutations that can contribute to high blood pressure. And so if we're concerned about family histories, then we really need to pay attention to that. As far as diet, it's thought that alcohol consumption contributes to about 10% of all cases of hypertension. And then we have an issue with excessive salt consumption, which is comorbid with stroke and cardiovascular disease. Some people are also salt sensitive, meaning that they will have an increased response to salt consumption. But this is seen in the research, but very hard to determine clinically. But it's probably just good to know that that exists. Obesity has a linear relationship with BMI and waist-hip ratio. And then with blood pressure, it's thought about 40% of all hypertension cases are due to obesity. And when you are within the obese range of BMI, you have a 2.7 relative risk of having hypertension compared to a healthy weight. And then finally, with physical activity has been shown to decrease the rate in which your systolic blood pressure rises and delays the onset of hypertension. And so it's something that it's important for us to, really push for and advocate for our patients. So just about 45% of adults in the US have hypertension, and 1 out of 4 adults that have hypertension are under control, meaning that they're medicated to the point where it's no longer an issue. So that means 3 out of 4 are not. In 2018, nearly 500,000 deaths included hypertension as a primary cause, and hypertension is just this huge contributing factor to a whole host of diseases, especially heart disease and stroke. 1 in 3 deaths caused by heart disease and stroke is the statistic for every year. And then 200,000 cases could be prevented if we just controlled hypertension with lifestyle choices. So if we're talking about the public outcomes or the burdens of hypertension, I think it's worth pointing out three figures. The estimated cost for hypertension prevention is almost $56 billion a year, and the prescriptions alone to treat hypertension cost almost $29 billion a year. And then it was found that between the years 2011 and 2014, that between almost $4,000 to $14,000 was the cost in medical care for each person. So there are some pretty distinct disparities that we see. We see more men affected than females, and then we see higher rates of hypertension in non-Hispanic Black adults compared to non-Hispanic whites, non-Hispanic Asians, and then Hispanic adults. So I think the most important disparity to point out or to highlight is that Black men are at the highest risk of dying early from heart disease and stroke compared to all other populations, and that hypertension is a contributor to this. So there is 143 preventable deaths per 100,000 people for Black men, and the next closest is 90 per 100,000 for American Indians. And it's been shown that Black men have a 2.5 risk of hypertension associated deaths caused by uncontrolled blood pressure when compared to other populations, and that's an incredibly large disparity. So one of the main studies that showed these increased risks was the All Hat study. It showed increased risk for the Black population compared to non-Black populations. And below it just listed some of the relative risks compared to the non-Black population. But more interestingly is that they made recommendations as to how to treat hypertension in non-Black Americans and then in Black Americans. So ACE inhibitors and ARBs and beta blockers were recommended for non-Black Americans, but Black Americans were recommended to have calcium channel blockers or diuretics. And so this has been known as the ABCDs. But it was also noted that diuretics should be the drug of choice for initial treatment for hypertension overall, but especially for Black adults. And then when cardiovascular disease was present, diuretics and calcium channel blockers are recommended over ACE inhibitors. So Black patients have the recommendation for calcium channel blockers over ACE inhibitors, but they also saw a high risk of stroke with those ACE inhibitors compared to diuretics. But there was no difference in effectiveness between the two treatments for the general population. And this is what led to that recommendation of diuretics for Black Americans. It is worth pointing out, though, that the ACE inhibitors have been shown to be more effective than calcium channel blockers for slowing GFR decline, so helping with renal disease. Now, all of this is to say that the goal of this is not to know the treatments, but just to highlight how different populations are treated differently. So we have this disparity between Black adults and non-Black adults in the U.S. And so there's a question as what do we do to overcome these disparities? And I think it's interesting to look at the Barber studies as potential answer. So these were studies conducted in Dallas County in LA, where Black men would be approached during their haircutting appointments to discuss their hypertension and to interact with pharmacists. And it was shown that they achieved better blood pressure control this way. Pharmacist-directed therapy led to a drop of blood pressure of 21 millimeters mercury, and 64% of the participants were within the goal blood pressure, so being below 130/80, compared to just 12% after 6 months. And it's just impressive to see that this somewhat novel approach led to great drops. So I included this chart to highlight a difference in medication between Black Americans and non-Black Americans. Really, this is coming from the Barber studies, and so what's being shown here is the prescriptions of different medications within the Barber study. So again, these are all Black participants, and it's after 6 months. And what we see is that nearly 99% of the participants in the intervention groups, so who were approached within the barbershops, ended up on an ACE inhibitor or an ARB after intervention, compared to just 42% of the control. And again, this is important to highlight because it goes against the ABC recommendations from the ALLHAT study from the previous slides. And we saw improved cardiovascular outcomes with ACE inhibitors. And so it's kind of calls into question what's exactly the right treatment here, or are we even looking at the right thing if we're prioritizing pharmaceuticals as the treatment. So I'm certainly not qualified to weigh in on the best pharmacological treatments for Black adults compared to non-Black adults, but it's worth discussing some of the barriers that contribute to the disparities we see. And I would say it's general consensus that treatment for hypertension has not been optimized for Black adults as it has for non-Black adults. In addition, they're often underrepresented in hypertension studies, which can lead to that lack of optimization. And then there's notably less contact with physician and providers. 23% of Black adults stated that they don't see a doctor regularly because they have perceived that they don't need a doctor. And then other issues for not seeing providers is that there is a perceived racial discrimination. And then specific to hypertension, it's been shown that the patient understanding of hypertension and the clinical outcomes aren't necessarily aligned, and so there may be a undervaluing of how serious hypertension can be. So when we were talking about risk factors, we talked about obesity, we talked about lack of exercise, and substance use like smoking and drinking. So we have videos that discuss how you can approach drinking and smoking and exercise and diet as well. But I wanted to pay more specific attention to the DASH diet as a lifestyle that can help reduce hypertension and reduce the risk of developing hypertension. And so the DASH diet focuses on having more fruits, more vegetables, and more whole grains. If you look at 6 to 8 servings of whole grains, 4 to 5 servings of vegetables, and 4 to 5 servings of fruit per day. And then you see an emphasis on fat-free or low-fat dairy options, a larger emphasis on legumes, seeds, and nuts, and less so than your lean meats and your poultry, and certainly less fats and oils and sweets. And so the benefits of this is that you see the risk of cardiovascular incident drop by a fifth, so down to 80%. Same with coronary heart disease, stroke, and diabetes. And then overall, we've seen a 11 millimeter drop in systolic blood pressure and a 3 millimeter drop in diastolic blood pressure. So I think these are good things to bring up to patients and be like, hey, this can take as little as 2 weeks to start seeing some of these benefits and just really push for that dietary change. Now, in addition to the DASH diet, I think it's also worth talking about salt because I think everyone knows that salt contributes to hypertension, but may not think about how much salt we need versus how much we eat. So the daily sodium consumption is 3,400 milligrams, but the recommended limit is 2,300. So we're almost half as much higher. And just reducing consumption by 400 milligrams can prevent up to 32,000 heart attacks and 20,000 strokes in a year. And then achieving that 1,200 milligram drop can lead to the prevention of 11 million cases of hypertension. And then I also just included this picture here saying like what is sodium free mean, what is a very low sodium mean, low sodium, etc. Just because I think it can be helpful to maybe discuss this with patients if they're talking about snack foods or other prepared foods. And then here, I've just included some basic examples of the DASH diet. This will also be in the syllabus, but I just wanted to point out what this could look like for a patient, since talking about servings per day is somewhat nebulous. And if it's not structured, you may have patients not really achieving that. So here's just super simple. Maybe take a look and have like, well, okay, if you're trying to do this and you can't think of how to get more, I don't know, fruit into your diet, you can talk about having like berries as dessert, right? Like a cup of fresh berries. So take a moment and just look it over. And then finally, I just wanted to include some pearls, some little bits of wisdom as to the non-pharmacological interventions that can be used. So if you look on the right, there is an approximated impact on systolic blood pressure for each quote unquote intervention. So if we're looking at weight loss, just general weight loss, whether it be through diet or exercise, you can see like a 5 millimeter drop. With the DASH diet, we see that 11 millimeter drop. Reduction in sodium is 5 to 6. And then if you look at aerobic exercise, it's 5 to 8. If you look at alcohol moderation, it's about 4. And so I think it's also important to look at this table and be able to just recall some of these as a motivator for your patients and say, well, you know, if you work on your drinking, your blood pressure, we can expect it to drop by like 5 millimeters, and that would get you into the goal range. So certainly something to just take a moment to look over and maybe commit a few of these to memory. Overall, hypertension has a lot of factors that can contribute to it, and a lot of these can be modifiable, and that's really kind of the take home today, is that even if we have, you know, almost half the population having hypertension, we can use multiple methods to chip away at it. 5 millimeters here, another 5 there, in order to get to a healthy blood pressure. So thank you for listening.